Hi, it's Dr. Centeno, and thanks for joining me today. You've got the power. Still in the process of moving, so this room probably sounds a little bit like it's got a bad echo, which it does. I'm going to try to hook up a separate mic here to see if that reduces some of that echo. So we'll see if that works. Let me make sure that that didn't mess things up. Let's see, audio, yeah, it looks like that's working. So if you're out there, just let me know if you can hear me just by putting something in the comments there. And today we've got an interesting topic. We're going to talk about the relationship between the levator scapula and C1 and C2. It's a unique relationship that isn't really talked about a lot. I was really unable to find much in the literature about this connection, and yet if you look at the way the levator scapula is built, it's very much associated with C1, C2. So we'll get into that, and then obviously then we'll go to questions. As usual, you can ask questions about this short topic I'm going to talk about. You can ask questions about anything else you'd like to. It doesn't have to be on this specific topic. So again, if you're just joining us, we're talking today about the CCI caused levator scapula tightness and what's the relationship between this postural muscle and C1 and C2. So let me share my screen here. And then we will go and start this short presentation. So the presentation today is, does CCI cause levator scapula tightness? And what's the relationship between these two muscles? So the levator scapula muscle that links the shoulder blade to the upper neck. What's interesting about it is that it's very much a postural muscle, meaning it's a muscle that your body relies on to maintain normal posture. And quite uniquely, I think, I was trying to search my head earlier today when I was putting this together, but I think it's the only long muscle that has an attachment outside of the neck itself that attaches to the upper cervical spine. Everything else that attaches like this starts someplace in the neck itself or goes to the head or skull. But I don't know of another long muscle that goes outside the neck that attaches to the upper cervical spine. And it's innervated by the C3 through C5 spinal nerves. Those spinal nerves are in general going to go through the cervical plexus, and then C5. Some of that's going to come through the brachial plexus. Now, symptoms of problems in this muscle, it's really pain in the side of the back of the neck that extends down to the inside upper shoulder blade. And this area is where the levator scapula attaches to the scapula. So this triangle here would be the scapula. As you can see, one of its jobs would be to rotate the scapula this way. Now, again, uniquely, it attaches to this upper cervical spine. So it's attaching to C1 and C2. And as we know, craniocervical instability for many patients is about issues at C1, C2. Also realize that we tend to see this area where the levator scapula takes its origin from the scapula itself or the shoulder blade, become an independent site of damage and tendinopathy. So sometimes that spot has to get treated, or the tendon there has to get treated when we're treating the neck. So I believe, and there's really no research on this that I've seen, that levator scapula is going to behave very similar to other long muscles. When you lose segmental stability at one site, then these long muscles kick in as secondary stabilizers. Now, they weren't really designed to do that, so they're not very good at it. They tend to get tight. They try to provide stability, to one segment on the other, in this case, C1, C2, and they get overloaded quickly. So they tend to get tendinopathy quickly. And these are just some cool little videos I found. This is part of Complete Anatomy there. So this one shows how levator scapula raises that shoulder. And in fact, there's a little bit more rotation of the scapula that happens than is shown here. But what it does show is that if you keep your neck stable, it can raise the shoulder. And so obviously, if you've got chronic tightness in this levator scapula, that one shoulder or that shoulder can come high. And then this next one shows that if we keep the shoulder stable and contract the muscle, how it can laterally flex the neck. Now, what's interesting is this is that open mouth lateral bending type motion where we tend to see C1, C2 overhang or sliding. So I would imagine that when that occurs, the signals go to the levator scapula, and levator scapula is probably not real happy about that sliding occurring. It probably tries to kick in as a secondary stabilizer. So in summary, pretty short today, the levator scapula is a long postural muscle that's uniquely attached to C1 and C2, whereas almost all other neck muscles attached to the skull. As a result, it likely plays a role as a secondary stabilizer of the CCJ when the primary stabilizers are down or offline. So I think that's all I have for today. Let me stop sharing there. And we'll go to questions, see if we've got any questions. Okay, we got a bunch of questions here. Let me try to get through this. Jim, do you think that an isolated C0C1 capsule tear without any laxity in the internal ligaments and without muscle atrophy could cause a heavy head feeling? Unlikely. Again, we have to be careful about these terms, capsular tearing. I know they're often used on digital motion X-ray studies, but we don't really have much justification to use them, meaning we don't really know that what we're seeing is in fact a tear in the capsule. So if that's under a DMX study, just realize that I would take it with a grain of salt. And in my experience, many of these DMX studies, they're sort of pointing out all these little things that we don't really know are abnormal. So let's go to the next one here. Forever Young. If I try dextrose with local provider, are they able to avoid collateral veins around C2 with ultrasound when injecting? So even if it does not go into a facet joint, at least there is no damage. No. So the biggest problem with using ultrasound is it would be extremely inaccurate for understanding if you are in a vein or an artery. And I think you really mean the vertebral artery, which would be the biggest concern in that area. And the answer is no. Ultrasound will not show you very reliably if you happen to inadvertently inject into the vertebral artery. And if you do that, anything could happen from nothing to a stroke to death. So that's why I wouldn't recommend using ultrasound in the upper cervical spine. If you're going to be injecting the upper cervical spine at that level, you need fluoroscopy with digital subtraction angiography if you're going to be anywhere near that vertebral artery. So no, regrettably, that wouldn't assure that. I finally redid an open mouth x-ray with my head more bended and found a huge overhang of C1 over C2. Well, great to know. Certainly, I think what you're talking about is the false negative rate that can happen when you don't have enough range of motion, meaning that the problem is there, but it's not detected. So one of the things I definitely would recommend, though, is that you determine how much overhang there is. And in addition, for it to be valid, you would have to make sure that the head stays straight and doesn't rotate while you're bending. And then there would also need to be a change in that periodontal space as well. Regenix and advanced by Edward Chen. How can a patient know whether their doctor is doing a defective prolotherapy solution? Is that a valid concern or a scrupulous worry? I don't know what you mean by a defective prolotherapy solution. I need to know a little bit more about that. Jim, do you think if someone has some mild but chronic laxity in the alar ligaments, those can tighten down if tension is taken off them by strengthening the muscles? Jim, usually what happens with ligament injuries is you get one bite at that apple. So for example, it's no different than if you were to damage your ankle ligaments and you damage them to a degree where they're irreversibly stretched. You get one bite at the healing apple and that either works or it doesn't work. Now, you might get a little bit of a second bite at the healing apple if, let's say, you were to go into a brace for 2 weeks or 3 weeks, and that's going to be balanced against weakening the muscles, which provide stability as well. So I don't think in general we're going to really get rid of a lot of laxity in the ligament by strengthening muscles. What we may do is provide better overall stability where the muscles kick in more and replace a little bit of the function of the ligament, because you have to realize that stability is half ligament and half muscle. So if the ligaments aren't doing their job, the goal is to get the muscles to do more of a job. Now, there's a limit to that calculus, but that should certainly be a goal. Krishna, what type of MRI is usually preferred? Does regular upright MRI with flexion extension without contrast work for you? Yeah, Krishna, it generally does. As I always say, I will always take more information rather than less in terms of imaging. If I had to grade types of imaging as likelihood of showing craniocervical instability if it's there, digital motion X-ray would be the winner. Then an upright MRI would come in second, and a distant third would be a CT scan. Krishna, can there be transverse ligament injury without alar ligament damage? It's certainly possible to see. I can think of 1 or 2 patients who are probably in that category. Now, there's probably some alar ligament damage, but the transverse ligament damage certainly predominates in those patients. Finn, does any of the trapezius attach to the upper cervical? The day my CCI symptoms started, my traps were spasming down left lower ribs. It doesn't attach to the upper cervical, but I think what you're noting is the same thing we were talking about before here, that these big muscles can get in on the act to try to provide stability. And so that includes the upper trapezius, as well as the levator scapula, scalenes, sternocleidomastoids. So a bunch of them can jump in on the act. Maya, hello. I've had levator scapula tightness for a few months. Could C2, 3, 3, 4, 4, 5 minor herniated disc be the cause? Herniation on the right side and tightness also on the right side. It's possible, as I said, we see that the levator scapula in most people is innervated by C3, C4, and C5. So you may be getting tightness related to that nerve irritation, or it may be due to something else. Now, what can also happen if there's not direct nerve irritation is that we can also see that the levator scapula gets very tight. And it gets very tight because the segmental muscles are offline due to those herniated discs or bulging discs. Yeah, so that's all good, Krishna. We certainly want to see patients as soon as possible after an injury, once we know that this isn't going to heal on its own. It's been advanced by Jeremy White. Can a shoulder injury cause this issue? My neck got really bad after I injured my shoulder. If the issue you mean is craniocervical instability, probably not. If the issue you mean is tightness in the levator scapula, sure, yes. Stefan, hello. It's almost time. Carlos has stunning landscape. See you soon. Oh, I will see you this week, I think, Stefan. Yes, it's a good place. I always tell patients it could be worse. I could be asking you to go to Detroit or something. Ulysses, I believe the scapula causes scoliosis too. Certainly, levator scapula is going to be more active on one side than the other if a patient has scoliosis. So yes. Christian, it's been 9 months since the onset of my symptoms, and my initial injury, according to you, is acute or chronic for PICL. Yeah, so we're looking, well, ideally for patients in that first 1 to 2 years. Obviously, we see patients that are much farther out than that. It's just that in my clinical experience, those patients that we get in that 1 to 2 year window tend to be more likely to be a one and done type treatment. Finn, since becoming unwell with CCI, I get muscles between neck and collarbone tightening upon walking. I suspect levator. Did these get atrophied, burnt out in CCI? Would benefit from training it. You know, certainly getting into a really high-level physical therapist who understands upper cervical instability is a good thing. They can help you do some strengthening. As far as strengthening the levator scap directly, it's probably not going to work. Amber, does levator scap cause the rising of the first rib? Mine are out of place weekly. Certainly by elevating the scapula, it can make room for a higher first rib, but it wouldn't directly impact the first rib. That would be more things like scalenes. And in the future, maybe 20 plus years, do you think a medicine will be developed that can temporarily tighten loose ligaments to help patients with connective tissue disorders? Yeah, I think we'll have genetic medications or genetic modification medications that will allow us to fix the genome in patients who have those genetic defects. However, as many of you know who have HEDS or hypermobile EDS or other forms of EDS, we're just beginning to understand the genetics of all of that. Regenics, mood advanced by Harry Winston. Is this something that can be treated as part of an appointment to treat CCI with a PICL procedure? Yes, we deal with it all the time. Ulysses, can the scapula be treated with Prolo safely? It can. That one spot that I was pointing to, where the levator scap takes its origin from the inside upper scapula, is a common prolotherapy site. Amin, is hearing cracking in my mid-back with minimum effort of movement means something wrong with the spine or some sort of instability? Here cracks with almost every move. It certainly could be an indicator of rib instability. Finn, do any other muscles in the neck get atrophied from chronic activation? Muscle guarding. Could autonomic nerves, i.e. vagus, get damaged by getting squashed between hard activated muscles? Yeah, Finn, it's a good question. You know, one that we see, I think is probably directly related to the vagus. I think I've talked about this before, is the sternocleidomastoid, because the vagus nerve goes right under the sternocleidomastoid, and sternocleidomastoid tightness is really common in C1, C2 instability. So I think we do have a patient subset that is suffering from vagus nerve issues and irritation because of that chronic sternocleidomastoid tightness. Rhonda, how do you know if there's tendinopathy in levator scapula? Yeah, Rhonda, it's a good question. We can look at ultrasound, but a lot of times if that area is very tender, it's probably, and that's been going for a while, it's probably developed tendinopathy. So it's almost not needed in most cases, i.e. if your levator scapula origin just started hurting a couple of weeks ago, then we'll treat your neck and see if it gets better. But if it's been hurting for 2 years, then it's probably tendinopathic, and we would add that to the treatment. Amber, does CCI contribute to edema in the ankles? Does pelvic instability contribute to edema in the ankles? Well, CCI wouldn't directly contribute to edema in the ankles, but pelvic instability or chronic low back issues can contribute to edema in the ankles. Now, a lot of that depends on what type of edema, and you'd obviously want to rule out all other more common causes like right heart failure, etc. Krishna, is it true that the symptoms which appear the first are the last ones to go? Not in my experience. Ulysses, CCI causes a lot of muscles to get tight. Sadly, these doctors know about this too. Certainly, CCI, as we were saying, can cause a lot of different muscles to get tight. Finn, I've seen a few CCI patients with pseudo double chin or that have lost their chin. Are you familiar with this? This is a compensation of the hyoid muscles to stabilize one's deep flexor neck, maybe neck flexors burn out. I think that there's two things at play there. Number one is I think we'll probably discover one day that a small mandible could be one of the risk factors for symptomatic CCI based on what we see all day, every day. And then the second is certainly CCI patients have various strategies, and one of them would be this, to try to help their pain and stabilize, depending on the type of CCI they have. So certain types of CCI, I think, put patients into this sort of chronically AO or upper cervical flex position, which gives this pseudo double chin. Finn, some CCI patients end up trying low-dose naltrexone for various symptoms, but this drug interferes with PRP injections' effectiveness. Not so much interfere with PRP's effectiveness, but a bigger concern is that it does mess with the anesthesia pretty substantially. So if you're on low-dose naltrexone, you're going to require much more anesthesia to get to sleep. And as a result, it just increases your personal risk of undergoing anesthesia. So on the one hand, it can be a lifesaver and very helpful for a lot of patients because it does help with the pain and some of the inflammation. On the other hand, it can dramatically increase procedural risk. Finn, have you ever tracked measures of CCI alongside rounds of PRP injections? For example, if you had some of the CXA 135 flexion, how would that typically change after each posterior PRP round? Now, CXA 135 flexion is not abnormal, just so that you know. When we get into the work done by Henderson et al. On CXA, 120 is pathologic. 130 is starting to become pathologic, and 135 would be normal. So you have to be careful with that number. As far as whether or not PRP rounds would reduce CXA inflection, I don't know that anyone's ever looked at that, but it's an interesting thought. Mark, I'm a medical student interested in physiatry, I'm interested in regenerative medicine, prolotherapy fixed my chronic TMJ issues. Is there any way I can shadow you for one day, just observe? Sure, Mark, just go ahead and contact me through my email address. I'll put it down here. We have a fellowship, and that's where we take 1 or 2 physicians a year. Usually those are physicians who have completed their physical medicine rehab residencies as a fellow and educate them in what it is we do. I just put my email address that goes to my desk down in the comments there. Nisa, could having the correct upper cervical adjustment create a levator scapular release if you are having tightness and pain in the shoulder area? It certainly could, yeah. Forever Young, for the upright MRI I mentioned before, would you look at translational BI, BDI, or CXAs and what scan is mostly about? Well, we look at a lot of different things in an upright flexion extension MRI. BAI is in flexion extension is pretty much identical to looking at grab oaks and flexion extension. We prefer grab oaks, but we also look at the position of the dens relative to the basion. BDI is not something I'm as concerned about because that gets into the world of vertical instability. And that's not something contemplated by our procedure. CXA is very important to look at, and whether or not it collapses in flexion. Connor, do you have much success and experience with a fully unstable thoracic spine and every rib attachment? I don't see this that frequently with EDS patients, but my thoracic is extremely hypermobile and lax. Nothing in there stays together, extremely weak. Yeah, Connor, we certainly treat various regions of the rib cage and thoracic spine in hypermobile EDS patients. As far as how many of those get treated, that's sort of an open issue and question, but it's certainly possible to treat several different areas at once. Listen, can you name other muscles that connect to the cervical spine? Well, lots of them, meaning everything from longus coli in the front to longus capitis in the front to some of the semispinalis muscles, etc. I think the unique thing here is a muscle that attaches to the upper cervical two levels, C1 and C2. That's the rare thing about levator scap. Regenix been advanced by DB. If nuclear treatment of my neck has increased my symptoms, do you continue or stop? I think the issue is my vagus nerve. I would stop. Again, some of that could be incorrect vectors. We certainly see that. Some of that could be that it's just not a good fit for you. Not all treatments are a great fit for all patients. Ulysses, what happens when you treat instability in the neck, shoulder, and mid-back, but not low back and hips? Can the instability return back to the upper area? You can make a video about this too. Yeah, that's another good video idea. We can certainly talk about how stabilizing, for instance, the pelvic ring or the lumbar spine or scoliosis can help the upper part, whether that's the thoracic or cervical spine. Andy, crazy to think that 50 years from now, the development of gene therapy and medications make heart mobility easily fixed by fixing the faulty ligaments. Not so much the faulty ligaments, but the faulty genes, and then new ligaments would get replaced. My guess is we'll probably even see that eventually in utero at some point, meaning when an issue is detected genetically, it'll be fixed in utero, and that person will then obviously get born with a normal gene set. Amber, I feel that my tongue tie, which causes forward head pressure, affects my upper cervical alignment, and though it may not cause CCI, I believe it exacerbates it. Yeah, Amber, I have seen a number of people try this tongue tie surgery who had CCI, and I can't say I've seen a ton of success with it. I know there's a whole thought process there, but I would put it in the same exact category as issues with styloidectomy, meaning that when we start to cut pieces of fascia or ligaments that stabilize the anterior neck, we cause instability. And causing instability in someone that doesn't have craniocervical instability is probably not as big a deal, but in someone that has CCI, causing any instability usually doesn't end well. Sean, I recently sent my DMX and brain cervical MRIs to your patient advocate. What is the timeline for review, initial consultation? Sean, you'll have to reach out to them. I don't know how far behind we are on getting in new patients for telemedicine. My guess is at least 3 to 4 weeks, somewhere in there, maybe longer, but that's something you have to reach out to the office on. Amin, is there any advice on what can we do to relieve our symptoms? CCI Oh, sorry guys, that was my bad here. Yeah, that was my bad. When it got disconnected, it means that the microphone got knocked out. So I'm going to go back and answer some of those questions. I apologize. Like I said, the guy turned off the power to the room that had the modem. So Isabella, I've noticed a lot of issues with that muscle pulling on my neck. Also weakness and pain in the shoulders. On my collarbones seem uneven and crack when rotating. Again, Isabella, I think as I said before, I don't have any specific medical advice for you. Nisa, when being injected with stem cells, going to cause further pain due to inflammation. I need to know a lot about what it is you're talking about under that term stem cells. Are you talking about bone marrow concentrate, stromal vascular fraction, microfragmented fat, something derived from an umbilical cord, all of that stuff? Isabel, I'm currently being treated for my neck with posterior PRP injections. I'm worried it might alter or hinder the healing process. I'd really need to know more about what healing process. Are we talking about healing from a PICL, healing from something else, etc.? Apparently we're getting an echo here. Finn, are there any conditions that can continually weaken the connective tissue? So not EDS or traumatic injuries, but something systemic. Yes, quite a few things can, systemic can cause problems, rheumatoid arthritis, SLE, etc. Amber, I've been leery to have a tongue tie. Yeah, so I would agree with you, Amber, that it's probably a better idea to address the instability first and then the tongue tie, if necessary, second. Following up on Amber's questions about the tongue tie, I heard there's no evidence. What about myofunctional therapy? Yes, I think that would be fine. Edward, are patient stem cells double checked to make sure they've been processed properly for PICL? Edward, not sure what you mean by double checked, but we look at, and we're talking about a bone marrow concentrate procedure. So we look at the total nucleated cell count. We look at live dead. We look at sterility within the lab. The cells are processed in an ISO 7 clean room, in ISO 5 hoods, et cetera, et cetera, et cetera. So maybe clarify a little bit more on what it is you're asking specifically about. Liam, how does one go about diagnosing specific location of ulnar nerve entrapment? So again, you're not going to probably get this from an orthopedic surgeon. You would need to see usually a physical medicine rehab doc that really specializes in this. So we talked about the 3 locations that are common: Guyon's Canal, ulnar groove, and the thoracic outlet. You would want to make sure that you get a hands-on physical exam that looks at all 3 of those areas. Now, if you want imaging, there is an MRI neurogram, and that MRI neurogram can be done to look at where the exact issue is. The biggest problem with that is it's extremely expensive to do, and you'd probably have to image 3 separate areas, which would be pretty expensive. Yeah, I got there. Isabella, how is that tight muscle running to the neck generally treated? Again, the focus here, if it's being caused by CCI, is to treat the CCI. We might also need to treat the tendinopathy associated with that chronically tight levator scapula. Amber Smith, Rhonda Isher Pickle, thank you. I've done TMJ facial therapy. It helped at that time. I was suffering and thankfully found I was in need of a C1 Atlas adjustment. That is what got rid of my neck and jaw pain completely. I just may have forward curve and pretty serious tongue tie along with CCI, even after therapy the back of C71. My children also have ties. I'm considering having theirs released. However, it scares me to, I'll wait for the rest of that one. Nisa, bone marrow concentrate for stem cells. If you're injected with stem cells, can it cause further pain due to inflammation? If so, how long will one feel pain inflammation in the area injected targeted? Yes, so bone marrow concentrate can be pro-inflammatory. the amount of flare-up is usually directly related to the amount of systemic inflammation the patient has. So, for instance, a normal healthy adult might only have 1 to 3 days of flare-up. An adult with metabolic syndrome, meaning heavy, high blood pressure, high triglycerides, poor blood sugar control, on the other hand, might be sore for 2 weeks. So it really just depends on the environment in which those cells are going into. Connor, when applying slight traction to my thoracic spine, I feel it separate in multiple areas and then slot clunk back together as likely rib attachments to the entire vertebral body separating. It's not exactly painful, but very concerning. Yeah, I mean, again, I understand what you're saying. It's certainly possible that that might need to be treated. And we can treat multiple areas, assuming you can tolerate it. Finn, can mast cell stabilizers such as ketofin or cromolyn diminish the effectiveness of prolotherapy, PRP? There are lots of mast cells in the connective tissue. Are they needed for regen? It's a good question. I don't know that anyone knows about that to the extent that any of those things can mess with platelet growth factor release. Then there may be problems and issues. So that's one specifically I'd have to dive deeper into to see if those medications can cause that. Now, in patients who have had mast cell issues or other types of immune hyperreactivity, we've generally just given them Benadryl IV during the procedure, and that's been pretty effective for them. Isabella, posterior PRP C0 through C7, I was referring to. I don't think that would probably help what we're talking about if it's due to C1, C2 instability. Amber, please ignore my comment. I'll probably respond to another comment. No worries. James, how important are C1 adjustments for treatment of CCI? Can any adjustments of C1 be all that is needed? Certainly, James, we've seen patients that's all they've needed. Usually the patient population that we get, obviously, is a little different in that the patients that we see tend to be those that are just the opposite, right? They tend to have tried upper cervical chiropractic. It won't stay in place. So we've got a pretty biased data set of patients because more often than not, they've tried upper cervical chiropractic and it's not holding. Stable on 3. Could instability be causing a snapping, clicking, or catching feeling around the Adam's apple area when yawning with possibly overactive SCMs? You know, that could be due to hyperreactivity within the omohyoid or stylohyoid muscles. So I would really consider looking at those deep anterior stabilizing muscles to see if there's an issue there. Rhonda, what relationship could CCI have to an elevated first rib? I'm told I have a breathing pattern where we use neck muscles and that's causing right first rib to elevate with excruciating pain at times. And could a bad breathing pattern contribute to CCI or CCI to a bad breathing pattern? Thank you. Yeah, so Rhonda, the biggest issue I think we see is the scalene muscles that attach to the ribs can get hyperactive in the same way that we're talking about the levator scapula. And those can also go into the higher upper cervical spine. And so that can then pull up on the rib and cause a high first rib. Now, it's also possible it goes the other way, that there's a high first rib due to scoliosis, and then that is putting forces rotationally up at C1, C2. So we see both of those types of problems. Any other questions? Again, I apologize for the craziness here today. Like I said, we had a worker who decided to turn off the breaker that went to the room that houses the modem. So no modem, no internet. And then I think I lost sound, didn't realize it. But I think we got everything going. James, just to follow up, my AO adjustments seem to be holding, but still have pain and vestibular neurologic issues. Yeah, James, so there may be a craniocervical syndrome, right? We talk about craniocervical instability a lot, but there's also a craniocervical syndrome, and that is that the upper cervical spine is generating symptoms, but there isn't much instability. Realizes the upper cervical spine and the structures there, upper cervical facet joints, the nerves in the upper cervical spine, vagus nerve, etc., that can cause those symptoms. But there doesn't have to be instability. There can be problems in those structures themselves. And when that happens, it's called the craniocervical syndrome rather than craniocervical instability. Nisa, what would cause one to have low stem cell count from their bone marrow concentrate? Will this affect the treatment CCI injected with stem cells? We don't believe, or I don't believe, as the provider with the world's most experience on ligament healing using bone marrow concentrate, that we see a relationship between a low stem cell count and overall healing. Now, that can affect other applications, things like knee osteoarthritis treatments. Also realize that the numbers that you're given in clinic after a PICL procedure are total nucleated cell count. So what that means is we're giving you the total number of cells and not the number of stem cells. So I know a lot of patients believe they're getting a stem cell count. They're not. They're getting a total nucleated cell count. So for example, the percentage of cells within those total nucleated cells that are stem cells would tend to be higher if you're younger and lower if you're older and infirmed. So a younger patient coming in with a lower total nucleated cell count wouldn't even be a concern about stem cell numbers, nor are we giving anyone a stem cell number. It's a total nucleated cell count number. Rhonda, following up with the first rib elevation, could a bad breathing pattern contribute to CCI or CCI to a bad breathing pattern? I think I answered that one already. Connor, in terms of laxity, do you ever have patients who don't tighten up after trying PRP, like their body doesn't respond? This is my biggest worry. Certainly, PRP isn't perfect for everybody. And for many hypermobile patients, prolotherapy, if that's all we're trying to do, can work well. Sure. Other questions I can answer, guys. Again, today we were talking about levator scapula and its unique relationship to C1C2, and just how spasm in that muscle could be related to instability. Obviously, there's lots of other things that can cause spasm in that muscle. So any other questions I can answer today? We had a little bit of a time period there where nothing worked just because we had a guy that was working in the building who turned off the breaker to the modem. Finn, is there any data on if there is a difference between injecting the facet capsule versus injecting immediately in front of it for either PRP or Prolo? I'm not sure what you mean by immediately in front of it. Again, I think as I've talked about, the whole facet capsular injection thing is a little bit of a scam, meaning that providers who don't really inject anywhere near the facet joint, they just put the needle somewhere in the vicinity of the facet joint, often will call that a facet capsular injection, but there's no data or there's no evidence that they're actually injecting the facet capsule. It's just sort of a name that was given to that sort of procedure. So it's a hard question to answer, because if you've been told that someone is injecting the facet capsules, usually that's just a scammy way to say, I don't know how to inject the facet joints. I was never taught how to do that. I don't have the equipment for that. But patients seem to want me to inject the facet joint, so I'm just going to stick a needle in there somewhere in the vicinity of the facet joint, and I'll call it a facet capsular injection to satisfy the patient. James, what's the best way to assess cause of upper cervical syndrome symptoms? Yeah, James, there's a lot that can be done in physical examination. You can directly palpate the upper cervical spine to see if the exam localizes to the upper cervical spine. You can look at other things that directly relate to the upper cervical spine, like movement causing the nystagmus, those sorts of things. So there's quite a few things you could do in physical exam to get a pretty good bead on if there's an upper cervical syndrome going on. And then ultimately you can treat the upper cervical spine and see if the symptoms go away to confirm your sense that the upper cervical spine is the cause. Stable on 3, would an ALF dental appliance interfere with the PICL procedure? Probably not, but just be a little careful because we've seen some patients get overly reliant on dental appliances and then sort of create a whole other separate set of issues we've got to deal with at some point. ZAs, anesthesia used for posterior PRP, for the posterior PRP procedure or another form of sedation. Anesthesia is sort of a blanket term that includes sedation. We would tend to use unconscious sedation or total IV access anesthesia. So total IV access anesthesia unconscious means that the person is given an IV and then that IV puts them to sleep and they're kept in that sleepy or asleep state. Connor, what could cause EDS to express rapidly and cause systemic ligament laxity that is very progressive? I have Lyme and my immune system doesn't function well. I know you have your own thoughts on chronic Lyme, but surely my immune system could be launching an assault. Yeah, Connor, you're talking to the wrong guy here, as I think you've heard before about the whole chronic Lyme thing. I don't think we have any evidence that's convincing that chronic Lyme causes ligament issues. And that's probably the same guy that turned off the breaker in the modem room, who's running the drill out there. So I apologize. Guys, other questions I can answer. I'm going to start wrapping this up because we're getting towards the end of the hour. Again, apologize for the break in internet stream today. But so just to wrap it up, we were talking about the connection between C1, C2 and the levator scapula. That seems to be a pretty unique connection. Maybe the only other muscle that could come close might be the scalene muscles, both of whom seem to get very, very tight when we're dealing with instability. One more question: is treating the upper cervical spine for craniocervical syndrome technically difficult? Yes, it's so technically difficult that the only place that can really treat all the causes is here in Colorado. So yeah, it's extremely technically challenging, even if we're talking about things like just injecting the C0, C1 joint. Out of 1,000 interventional spine doctors, just to give you an example of it, probably only 100 will attempt to inject C0, C1. Out of that 100, only about 10 might have done it more than a couple dozen times in their career, and only 1 or 2 might do it on a regular enough basis where they'd feel extremely confident in doing that procedure. So it's incredibly technically demanding for sure. Okay, guys, thanks so much for watching. I will be here this Friday. Hopefully we won't have a guy that turns off the internet connection and uses loud drills. So thanks for your patience and have a great day.